Hi, welcome to today's webinar, the Transplant Nephrologist Compensation and Workforce Composition Analysis from a Survey Part 1, hosted by the AST Medical Directors Task Force. In a moment, I'll turn the discussion over to our moderators, Dr. Christina Klein from Piedmont Transplant Institute and Luke Preczewski from the Miami Transplant Institute, who will introduce our presenters, Dr. Monadoshi from the University of Michigan and Dr. Niraj Singh from the Willis-Knighton Health System. Before we begin the main presentation, we have a few housekeeping notes to help you engage with today's discussion. There is a viewership polling question displayed for the audience. Please take a moment to answer this question while we do the remaining announcements. This webinar is being recorded and will be available to you after the session. Please note that your lines have been muted so that only the presenters can be heard for the recording. If you have a question for our panelists during the webinar, please use the Q&A section to submit your questions for consideration. Questions submitted via the chat session may be missed during the presentation. If there are questions we don't have time for, we'll either answer them individually offline or post the full question with the answer following the webinar. Finally, when you log off at the conclusion of today's session, you'll be directed to a short survey. Please fill this survey out to help us keep our content current and engaging. I'll now turn the session over to Dr. Klein and Mr. Preczewski to begin our presentation.
Thank you, Melissa. And on behalf of the AST Medical Director Task Force, we thank all of you for your interest in our webinar today. We particularly wanted to extend a thank you to those in attendance who participated in the compensation survey. We're very excited to share the preliminary survey results with you all and look forward to your questions at the end of the presentation. So please submit your questions during the presentation as Melissa directed. Our first presenter is Dr. Monadoshi. She is a clinical professor of medicine at the University of Michigan Medical School. She's the co-medical director of the Kidney and Pancreas Transplant Program and is very involved in the AST. She is on the executive committee of the Living Donor Community of Practice and also serves on the education committee in addition to being on the medical director task force. She is funded by NIH grants, Apollo, and novel biomarkers to predict outcomes in kidney transplant. Her portion of the presentation will be followed by Dr. Niraj Singh. In addition to being a physician, he holds an MBA and is a fellow of the American Society of Nephrology as well as the AST. He is the medical director of the Kidney and Pancreas Transplant Program and an associate professor of nephrology at Louisiana State University in Shreveport. He also serves as a member at large of the KP Community of Practice and is the co-chair of the Medical Directors Task Force. So we'll start with Dr. Doshi.
Thank you, Christina, for the kind words, and let's get started. Neeraj, next slide, please. So neither myself or Niraj have any disclosures relevant to the presentation. Next slide. So the background, the Medical Director Task Force was established in July 2019 by the AST Kidney Pancreas Community of Practice and the AST Executive Board to support the unique experience and training of kidney transplant medical directors. Work of the task force included the detailed development of description of the role of medical director, the development of a forum, both virtual and hopefully someday in person, to share our practices and discuss issues pertinent to our leadership, and then completion of the first transplant nephrology compensation and job satisfaction survey. So these are the members of the task force, and let's jump on with a polling question. Let's see how many of the attendees completed the survey. Please answer the poll question. Let's move along. So the goals of the survey were to focus on the composition of the Transplant Nephrology Task Force, focus on the work RVUs as it relates to RVU and clinical FTE, and then also talk about compensation, benefits, research support, and lastly, job satisfaction. For the purpose of today's survey results, we're going to share with you only the top 3 goals, that is, we'll review the demographics, work effort, and compensation. Next slide, please. Survey questions were developed by the Medical Directors Task Force and were adapted from previously conducted surveys such as Transplant Hepatologist Survey and ASTS Transplant Surgeon Survey. The survey was approved by AST Education Committee on March 3rd, 2020. The survey was open to the transplant nephrologist on March 9th and was sent out to over 1,100 AST members who identified themselves as nephrologists. The survey was also promoted by different COP hubs after the approval from the leadership. And lastly, at the very end, we sent personal solicitation to UNO's medical directors to reach out to the faculty. Responses were completely anonymous and de-identified. Next slide, please. So, as I mentioned before, the survey was sent out to 1,100 AST transplant nephrologists. 365 responded. We excluded survey responses from 27 individuals who are currently not actively practicing transplant nephrology. 68 of them did not report compensation data. 10 of them were practicing outside United States. 7 were from Canada and 3 were from outside of North America. 19 were pediatric nephrologists. So at the end, our survey results from today reflects the responses of 241 adult or medicine pediatrics transplant nephrologists who are actively participating in United States. Next slide, please. The results that we are presenting today have not been statistically analyzed, and we are just presenting descriptive data of our survey results. First, let's tackle age, okay? This graph shows you distribution of age across the survey respondents. In the blue bar here shows the results for the survey respondents, and as you see, we had representation for each and every age group. The red bar, however, right here shows the distribution of the AST membership who registered themselves as nephrologists. There were fewer respondents from the higher age group, 65 and above. Next slide. With regards to gender, the pie graph on the left shows the gender distribution of the survey respondents, and that on the right shows for the AST members identifying themselves as nephrologists. What we see here is that we had fewer female respondents, survey respondents, than the general AST membership. With regards to race, the pie chart here shows the racial composition of our survey respondents. 49% were white, 39% were Asian. There were only very few, around 2% of Black physician respondents. Next slide. This slide shows you the geographical distribution of the location of practice of survey respondents in blue. As you see, we had representation from all parts of the country. The representation was similar to that of AST members registered as nephrologists in red. Next slide, please. With regards to kidney transplant volume, this graph shows annual kidney transplant volume for programs represented by the survey respondents in blue. So we had transplant centers performing less than 50 kidney transplants a year to those performing over 300 kidney transplants a year. As you see, again, we had very good representation of programs of all size. The red bar represent kidney transplant program size for AST members identifying themselves as nephrologists. What you see here is we had less representation from the smaller programs. Next slide, please. Looking at the professional education data, what we see is just under less than half of them were from US medical school graduates, and over 72% had finished AST fellowship in nephrology. Next slide. So the next question we asked the respondents is, what percentage of your job is allocated to transplant nephrology? What we see here is overwhelmingly, more than 3/4 of our respondents spent at least 75% or more time in transplant nephrology. Next slide. So the next question we asked is, what percent of your job is allocated to general nephrology and dialysis? what we see is only 12% spent any time doing general nephrology, and even fewer, 4% spent time in outpatient dialysis. So our survey respondents spent a lot of time doing transplant-related activities. So the next question, next slide, please. We asked is, what is the distribution of your professional responsibilities? As you see here, over 70% of the individuals spend most of the time doing clinical work. Very few, maybe under 20% time was spent doing administrative and research related activity. Next slide. Looking at the administrative roles, what were the common titles that were carried by the individuals? We have to say 54%, around 131 of the 241 respondents had at least one major administrative title. 8 respondents had multiple major administrative titles, and the titles included anywhere from transplant center director to UNOS kidney pancreas medical director, UNOS kidney director, UNOS pancreas medical director, and OPO directors. Next slide. With regards to practice affiliation, as you see here, over 70% of our respondents were affiliated with a university hospital. Remaining 16% were affiliated with an independent transplant center, 12% represented private practice group, and then we had combination of VA administration, and some, as I mentioned before, we had included med-peds practitioner, so some also had affiliation with pediatric hospitals. So at the end, some of our respondents had more than one practice affiliation. Some, it was either a combination of being in an adult university hospital with some time spent at the VA, or some with some pediatric affiliation. Thank you. Next slide. The next question we asked is, what is the alignment of transplant nephrology with the hospital? 47% of them responded that the transplant nephrologists were hired by academic departments who in turn contracted with the hospital to provide transplant-related services. 41% of the respondents were directly hired by the hospital. And as mentioned before, 12% of the respondents worked in a private group setting. So with regards to the rank and tenure of the respondents participating in a university setting or an academic setting, which were only 175 respondents, on the left-hand side, we see a pie diagram showing the rank profile of all the respondents. And you see we had a very good representation across all different ranks, with 44% being assistant professor, 27% representing associate professor, and then we had 25 representing full professors. Moving our attention to the right-hand pie diagram, only 20% were on the tenure track. Now, after describing the composition of our respondents, I will move over the presentation to Dr. Singh, who will now talk about the RVU and the compensation data.
Thank you, Mona. Thanks to AST and AST Medical Directors Task Force for giving me this opportunity to present our survey results. So moving on with the RVU and compensation data. In response to the question, are your work RVUs tracked and reported to you? 181 respondents said yes, but only 98 out of 241 total respondents, which is about 40% of total respondents, reported their target RVU. The average work RVU target per year reported was 4,581. And this target was based on different sources, including AAMC, MGMA, UMC, as well as agreement with the division head or department head. Just to remind our audience, this target was recorded from attendees, from participants who were practicing predominantly transplant and did little or no dialysis. Looking at the relationship of RVU and academic rank, out of the 98 participants who reported their target RBUs, 94 of them had academic affiliation. For assistant professor, there were 35 respondents and they reported their RBU target of 5,166. Associate professor, the reported RBU target was 4,246, and for professors, the target was 4,400. Looking at the base compensation, there was a wide range in base compensation with variation from less than 100K to more than 500K. The median base compensation is, as highlighted, was in the range of 201 to 250K, and 70% of the total respondents had base compensation in the range of 151 to 300K. Close to 90% people had a fixed base salary, but since participants were allowed to choose more than one responses, as highlighted in the as shown in the column first, 18% respondents also chose work RVU based base compensation. For a small number, the base compensation was also based on cash collections, grants, quality metrics, or they were not sure about the structure of their base compensation. Next, we asked our participants about the incentive compensation or bonuses. So 1/3 of the total respondents did not receive any incentive or bonus compensation the year before they filled out the survey. For the rest, the bonus ranged anywhere from less than 10,000 to more than 40,000. Predominantly, the clinical workload or clinical productivity decided the bonus, as 68% respondents said that they received bonus or incentive compensation based on their clinical workload as reflected in their work RVU, E&M based collection, financial performance, or quality metrics. 1/3 of the total respondents also mentioned that they received incentive compensation based on their academic productivity or service and teaching responsibilities. A small number, 13%, mentioned that they also received other cash compensation in addition to the base compensation or bonuses. And some of the reasons for this other cash compensation were mostly administrative responsibilities, like being a medical director of kidney or kidney pancreas program, having dialysis unit ownership, general nephrology calls, moonlighting, as well as non-clinical revenue from the practice. There were only 9 medical directors who actually gave their medical director cash compensation, which ranged from 5K to 180K. So there was a wide range in the director compensation. For majority of respondents, the salary came from university or division of nephrology, 63%, but salary also came from other sources, including division of transplant surgery, 5%, group practice, 19%, transplant center, 16%, and hospital, which was about 36%. Then there was small number of respondents who mentioned that their salary came from other sources, like including Department of Pediatrics, Division of Transplant Nephrology, Medical Director Fund, and so forth. In response to the question, is your time spent in performing non-billable services like attending pre-transplant selection committee, chart reviews, post-transplant lab reviews, taking organ offer calls, etc. accounted for? So 1/3 of the respondents said no. 80 respondents said yes, that they do get compensated for these non-billable services. And some of the examples or some of the ways they quoted how they got compensated were getting a fixed dollar amount per hour, getting assigned proxy work RVUs, getting some reduction in their target RVU, getting that compensation rolled into the medical director fees, getting extra FTE or bonus or points towards extra bonus, or getting that compensation rolled into their base salary. Less than half of the respondents reported submitting timesheets to CMS for pre-transplant work. Rest were either not sure or they said no, they did not submit the timesheets to CMS. So to summarize, the total compensation included base salary, which was fixed for 90% of the respondents, bonus, which predominantly respondents got it for clinical productivity, but 1/3 also got it for their academic as well as administrative responsibilities. Compensation for non-billable services, which was again for a small percentage of the respondents. And finally, other cash compensation, which was mostly for administrative responsibilities, but also included non-clinical revenue as well. Next, we looked at the factors affecting the base compensation, including age, years in practice, academic rank, geographic region, title, and practice type. So looking at the age as a factor impacting base compensation, as you can see, the highlighted rows shows the median base compensation for those different age groups, and base compensation did go up with age. Base compensation also went up with average years post-fellowship as well as years practicing transplant nephrology. Next, we looked at the base compensation by academic rank, and the highlighted rows shows you that for instructors, the median base compensation was less than 200K. For assistant professor, it was in the range of 201 to 250K, associate professor 251 to 300K, and for professors 301 to 350K. We also looked at the base compensation by different geographic regions, and the median base compensation has highlighted was similar across all regions in the range of 201 to 250K, except for South Atlantic and for West, where participants had a base compensation in the range of 251 to 300K. We need to further explore these differences. Base compensation also went up with increasing professional responsibility, typically administrative responsibility. So as administrative responsibility went up, the base compensation went up with concomitant decrease in the clinical responsibility. Looking at the base compensation by title, there was a wide range in compensation for both kidney as well as kidney pancreas medical directors, as shown in those color codes at the bottom. The median base salary for kidney medical directors was in the range of 251 to 300K, and for kidney pancreas medical directors, it was in the range of 301 to 350K. We also looked at the base compensation by practice type, and again, there was a wide range in base compensation for those employed by VA, university hospital, private practice, as well as non-university hospital. The median base salary for those employed by VA and university hospital was in the range of 201 to 250K. Those employed by private practice was in the range of 251 to 300K, and for those employed by non-university hospital was in the range of 301 to 350K. Next, I'm gonna hand over the mic back to my co-speaker, Dr. Doshi, to go over the strengths, limitations, and summary of the results.
Thank you, Niraj. So, this is our first shot at this survey. So I think I want to first start off with highlighting some strengths. This is the first survey to specifically examine the transplant nephrology compensation. We had a really good geographical representation of US transplant programs. And most of our respondents spent a lot of time doing transplant nephrology, and 80% of their time went in doing clinical transplant nephrology. So I think this is very relevant to the audience. Next slide, please. However, our survey did have some limitations. The lack of generalizability of the results of a survey, as I highlighted before, we only had a response rate of 33%. We did not adequately respond smaller transplant centers, those who perform 50 or fewer transplants a year. We had more representation from the academic centers. 73% of our respondents had an academic affiliation. 50% of our respondents had major administrative titles, which may not be universal for every single practicing transplant nephrologist. And we had underrepresentation of females and individuals 65 and older still practicing transplant nephrology. Nevertheless, there are some takeaway points from our survey results. This is the first look at our data suggests, as Neeraj pointed out, that salary is influenced by years in practice, administrative responsibility, practice type, and academic rank. There are other differences in compensation by geographic area, gender, race, and administrative title, which need to be explored in future analysis, and we will host additional webinars at a future date. 90% of respondents reported having a fixed salary, and salary support was often from multiple sources. 1/3 of respondents did not receive any bonus or incentive. Among those who received bonus, it was predominantly based on their clinical workload. 2/3 of the transplant nephrologists do not have a target RVU. Among the 98 that reported the target RVU may have their practice influenced by the number of RVUs they need to generate, and therefore may not be representative of average RVU by transplant nephrologists. Other pertinent findings include 44% of them do not complete time studies, and 67% of them do not know how they get reimbursed for non-billable time. And most of the transplant nephrologists spend a significant time catering to non-billable services. So I think a lot of questions need to be answered in our future analysis and subsequent survey. And I hope you're enthusiastic and will participate in future surveys. Thank you very much for your time and attention. And we are open to taking any questions.
Thank you very much for a great presentation. So we've got a couple of questions coming in here. First, from Abdul Reza Hararian, were the compensation amounts adjusted for the cost of living in the respective geographic locations? Dr. Singh, since you did the compensation part, do you want to take that one?
No, I think this is, as we mentioned, we need to look at this further. We did not adjust for cost of living, but yeah, of course, we did look at different geography, and there seems to be some differences which we need to look into more deeper and then come out with answers.
Thank you. Yeah, and I would add to that that when you look at the breadth of those geographic regions, it would be hard, to have a single cost of living. It's very, it's very different to be in a city in one of these places versus in a rural area. And when you look regionally, that covers a pretty broad area. So I think some of that is going to inevitably be fairly limited. We had a question about the slides being distributed. I believe the webinar is being recorded, but I'm not sure. We'll circle back on whether the slides can be distributed. And a related question then, will the results be shared? And that answer is very likely yes. So it is our intention as a group after our next webinar to put together the right form of sharing the results out, and that'll take us some more time to put together, but definitely that is part of the plan. Another question here, would you conjecture that the average work RVU for transplant nephrology is potentially less than what is reported here due to the lack of targets for the majority? Anybody want to take that one? All right, nobody jumping up to grab that. I think it's difficult in the data to conjecture about what people might be misreporting or something like that. But I think it's a very fair question in terms of the fact that there are a lack of targets, and I would think that at least suggests the possibility that folks are not necessarily well in tune with their RVUs. And that's consistent with my experience in compensation for transplant nephrologists. In many cases, that's on a salary basis or otherwise set up in a way that that might not tie them into their work RVUs the way, for instance, a private practice where your compensation or your incentive is very directly based on RVUs. So I think it's a fair question. We can't answer it with the data, of course, but it's a fair question for sure.
I think, Luke, I would like to add that I'm sure most of the institutions do, keep a track of target RVUs, but if it does not affect the salary, probably people are unaware that what is the target RVU, right? So perhaps those 98 people who responded, as you suggested, have their salaries at stake if they don't reach the RVUs or et cetera. So perhaps, and I think maybe personally, I feel it's a time that we move away from RVUs because we spend so much time doing many other things that don't generate RVU, but that's for a later discussion or a subsequent survey.
Yeah, and I want to echo those comments and taking the sort of transplant administrator perspective on this. Normally, I love holding physicians accountable by all sorts of terrible metrics, but I think if you look at an alignment of appropriate incentives, work RVUs are not the best measure of the productivity of transplant physicians. They just aren't, and this is highlighted in the fact that our system, for better or for worse, puts a lot of premium on procedure-based activities. And so, when we're looking at our medicine physicians, we want them doing the things that are most valuable to our program, many of which have 0 RVUs, if that's sitting with coordinators and reviewing a chart, or they have they have low RVUs if it's seeing patients in the clinic, which can take, as everybody on this call knows, a long time with pretty limited RVUs. Whereas if you can get yourself able to go, if you want to go run some CRRT in the ICU or whatever, you can get a lot more RVUs in a half day of doing that than a whole week of being a great transplant nephrologist. So definitely my message to anybody determining compensation for transplant physicians would be to be very cautious about how you use RVU targets and make sure you're not creating pretty profoundly misaligned incentives.
So just to add to that, I think work RVU is particularly problematic for our specialty, transplant nephrology, because a lot of things we do outside clinical work, we do a lot of non-billable work, we do relationship building, protocol writing, which is not accounted for, which is not captured by the work RVUs. So as even our survey shows that 2/3 of the respondents said that their work RVUs were tracked, but only 1/3 said that they had a specified work RVU target, which they were trying to achieve. So I think it is the right thing that centers move away from work RVUs for the transplant nephrologist, or come out with some better metric to capture what we actually do.
Yeah, that's great. That's great. So we got a couple of questions here regarding differences, gender differences in compensation, and so that actually is a topic that we intend to explore further. And so we're gonna leave that as a reason to come back for our next webinar because this is something that we're very interested in, and we're working on how best to analyze and present that. Not surprisingly, the preliminary analysis shows it's a complicated area, and we want to be very thoughtful about the way in which we present that. But we think that's a very important discussion, and absolutely we'll be returning to that. I don't know if any of our other panelists want to comment further on that.
I think, Luke, in addition to compensation, we also want to look at leadership position and promotion.
Yep.
As we know that there are gender gaps as it pertains to salary, academic ranks, promotion, and many other things. So we want to not just explore salary and compensation, but all these other areas too. So please join us again and, look out for another announcement from Melissa about our webinar.
Definitely.
I would further add to that those of you who did the survey know that there was a job satisfaction section, and due to time constraints, we weren't able to present that here, but we also, will present that from a sex gender perspective as part of the future webinar.
Thank you. All right, so Satyarth Cole is asking, I was surprised that the median salary of associate professor and professor is 300 to 350. Is this region specific too? Dr. Singh, I'll put it back to you as our compensation guy.
So we saw there are differences by rank as well as by region. So I will not be surprised if there are if those differences also are the differences in salary for associate and professors is also region specific. We have that data. We can actually look further into it.
And I would just, make a really emphasize on the point that the numbers you see here are not the literal numbers you should take home, because as Neeraj pointed out that, that complex interplay of how a person is compensated. Some are just fixed salary, some get bonuses, some, folks get reduction in work RVUs. So it is a complex, very complicated mathematical model that varies from center to center, and people get reimbursed differently based on the administrative title. So it's not like you can look up yourself, oh, I practice in Midwest and this is my academic title and this is the salary, because people, we cannot pull out every single way that people get reimbursed. And maybe Luke, do you want to add to that? Because I think we had a lot of discussions among ourselves about, what is the right salary and is this something that people should take home?
Definitely, and I think that I agree, and I think it's a very it's proven to be very challenging to as we've looked into this and to try to see I think all the variables that go into this have made it fairly complicated, and we were happy to see a fairly robust survey response. I know in terms of the survey research volume, you want these really, really high rates, but I know that in general, when you do salary surveys, actually you tend to have very, very low rates of people comfortable providing that information. So I think we were pretty pleased with the number of people who responded, but even with that great response that you guys gave, as you start to slice and dice this, it gets a lot harder. And so when you start to break out the geography versus the academic rank and everything else, these things fall very rapidly into pretty small slices, and that makes it a lot harder to draw conclusions. And I think that's a critical takeaway from this, is that there's not a great answer. I would also say from my experience, I think every center where I have worked struggles at times to know what is the right method for compensation of transplant physicians and what are the right types of benchmarks to use from that. There have been times we looked at various things that are out there and we found they don't fit well, and you look at people are getting offers from other centers that are significantly higher, so intuitively to be competitive in the marketplace, you need to pay more than the benchmarks would suggest. At the same time, I think as an administrator, the last thing you want to do, and the same thing for our physician leaders, right, is encourage people to go get other offers as a way to increase salary. That's not really the best for all of us to have that happening a lot, and a lot of insincere interviews and things like that. So that's part of why we felt the need to try to survey this and get a better understanding would be to our benefit, because this continues to be a challenging problem.
I would also like to add that our smaller group and our larger group with the Medical Directors Task Force, we learned a lot about just survey limitations and survey design as well. So just the way that we designed the survey, although we had the ASTS survey and the transplant hepatologist survey to really look at as predecessor surveys on salary in our field, we learned through analysis of the data what we could do in crafting the survey questions in order to, add strength to a future survey and be able to analyze it more efficiently. So it's been very helpful in an educational experience, just in terms of being the first survey in our field. What will we do differently in the future in order to encourage more participation and capture some of this more granular data?
Definitely, and I think it's important to highlight that around the country people are paid by very different methods, and so at every organization the structure looks a little bit different, and that's one of the complicating factors, both in terms of structuring a survey like this and analyzing those results, as well as all of us dealing with how do we determine compensation for transplant nephrologists, because it ultimately we're going to go fit it into our own systems. One of the examples this group talked about quite a bit was the idea of what is base compensation. And I know from different centers where I have worked, as well as other folks I've spoken to, in some places, base compensation is the core means of compensating physicians, and it represents most of their salary, other than maybe some variable comp on top of it. And so base might be a significant number. At other places, base compensation is defined effectively as the minimum salary you have to pay a tenured faculty member if they're doing no clinical work. So at some places, the base compensation can be, what they feel like they're going to pay an English professor who's not working. So obviously that's not going to work well for busy physician practices, and it injects a lot of complexity into even how we ask the questions and how we analyze the results that further complicates what's already tough data to work with.
I think, look, Neeraj presented that the incentive for the 2/3 who got an incentive bonus, it ranged from 10,000, like maybe $1 to more than 40,000. But
Right.
Those who received cash compensation, probably most of the medical director, right? The 9 who responded, anywhere from 5,000 to 180,000, right? We all want that job of that person making $180,000. But the question is, like, did he have a very low base compensation? And that 180,000 just made up for it. So Satya, we gave you a very convoluted answer to your question, but I think the whole process is very, very complex.
Definitely. Another question we have here: did you find any correlation between center volume and administrative time of administrative effort? My colleagues can correct me. I feel like we did not look at that, but we certainly could. I think it's an interesting question, and it's a good note for us to take back for some of our further analysis. Certainly makes sense. So we can take a look at that, and I can't give you an answer today, but I think we can in a future webinar, because I'm really here to sell you on coming back for our second webinar. That's my primary role.
And tell your friends.
Yes, right. Bring it. Yes, come back and bring a friend. Absolutely, absolutely.
And take our surveys, our future surveys too.
Definitely, yeah, because that's we can power these even better. I know it's tedious to fill those things out, but the more responses we get, the better we are, and we're committed to continuing to do this for the community if the community wants it. And I think in a lot of ways you'll vote with your mouse in whether you complete them, and if we see robust response rates, we'll try to do more of these and better. We'll learn from what we've done in the past and try to serve the community with the best possible information that we can put together. Another question here: the amount of compensation variability is incredible regardless of the rank. Did you adjust for cost of living in geographic areas? I think we sort of already answered that question. We did not do a cost of living adjustment by geography, and I think it would be challenging to do that, because even within our geographic regions, there's a lot of variation, and we did not ask for hyper-specific information. So we were to preserve anonymity, we didn't have people give us a zip code or something that would allow us to do an appropriate cost of living adjustment. But to the first point, I think we all agree, one of the takeaways here is the significant variability. I don't know if any of you else has any comments on that.
Yes, I just wanted to add to that. We really debated a lot about encouraging people to fill out the survey, and thought about asking about zip code or center code, and decided against that, just because we did want people to feel free to share information about, their base salary and bonus structure. And so the regions that we looked at were like South or South Atlantic. There were several different states which could have different cost of living. And even within a state, you could have, 3 transplant centers where 2 are in a metro area and 1 is not, such an expensive cost of living. So that the cost of living, I think, will be impossible to discern from our data, the way that it was collected.
Definitely. Thank you. So we've answered the questions that we had during the chat, although please feel free to post any more. We did receive a few in advance, and so I'm going to put these to our panel as well. The first is, how would you compare the compensation for a transplant medical director and a dialysis unit medical director? Does anybody want to speak to that at all?
We did not collect data on dialysis medical director compensation, so it's very hard for us to say, how they differ. And again, as I mentioned, even the transplant director compensation varies from center to center. Some give, no change. There's no change in any RVUs if they have one. Their clinical workload stays the same, but they get compensated over and above as a incentive or cash compensation. Others may have a reduction in the clinical duties, clinical effort. That's what Neeraj presented, and may not have a significant, or maybe have a small amount of cash compensation or incentive. So I don't think so it's very easy to carve out like what is the stipend that comes directly because of the title of medical directorship. Anybody else wants to add to that?
I would agree with that very much. I think some people may have in an original offer letter some sort of delineation that says this much is for medical director and this much is base and this much is that, and honestly at some institutions that's taken very seriously, attached to time studies, et cetera. At other places it's just a means to arrive at compensation, and other than putting it in a letter, it's really a question of what's my total salary. That's what folks are looking at. I would also add that on the dialysis center director side, that has been an area of significant federal regulatory oversight, with the concern for stark anti-kickback issues, and so that's a fraught area in general, with with an evolution from old methods of doing it toward the established safe harbor practices that effectively reduce the amount of compensation available for those roles, because of a concern that high compensation for those medical directors run afoul of the Stark rules.
So just to add to that, I think we don't know how do you get paid as a medical director for dialysis unit, if it is standardized or not. But what we know from our survey results that there is a huge range. There is a lot of variation in how medical directors get paid. I think, of course, it depends on your center size, center volume. It depends on how much administration time are you allocated. If you're allocated 5% of your time in administration, you may not be paid as much as if you're contributing 50% of your time in administration as a medical director.
Great. So we've got a new question in from Angelo de Matos, and many non-medical institutions are more transparent in terms of compensation across their workforce. Do you see any movement in the transplant community in that direction, and should we advocate for that? Any thoughts from the panel? I do have thoughts on that, but any thoughts from anybody else first?
I'll only answer this from our own personal perspective, and you being in administration may have that additional perspective, but I do agree with that. I think that that's one of the reasons why people are interested in even having the results of a salary survey be available and be shared, because it is important to people to understand how people are paid. And especially for young transplant nephrologists coming out of fellowship, I think that it's really, I learned the most by word of mouth. I'm going to trusted people, what should my salary be? What should I be looking out for? And I feel that more transparency is better. That being said, you mentioned a lot of things that transplant nephrologists do that are non-billable, right? So it does have to be taken in context of, there's a lot of our job that we do that we can't directly put in a nice, clean, it's not as easy to define those roles and how we should be compensated. So I personally believe in more transparency.
Yeah, I agree, and I think, you know, actually, Dr. D'Amatis asked this question. He and I worked together in the past in the University of California system, where salaries are actually available online, right? So there are you know, some government institutions that that consider this a matter of state sunshine laws. More than that, I think if you look at some of the data on sex gender disparities and racial disparities, one of the easiest tools for helping to repair that is actually salary transparency. So in a lot of cases, the just exposing it, just, you know, sunlight is the best disinfectant kind of thing. If everybody at an organization knows what everybody else makes, it helps resolve these issues if systematically their bias has crept into compensation systems. That obviously comes with problems too. There's no doubt about it. But from my perspective, the value of helping to eliminate some of the disparities that exist in pay is a pretty powerful tool. I would say that I think healthcare has been fairly slow to this. I don't think we're an industry that has jumped to the front of the line in doing this outside the government institutions, where it's sort of something that's been compelled, and just anecdotally, I think people obviously talk about their salaries everywhere, but I don't feel like that happens any more in healthcare than other organizations, and quite possibly less.
I want to add another thing. Apart from being just transparent about salary, I think we need to be transparent about, you know, like, how do we find funding for non-billable services? Like, you know, if CMS is paying, then that fund needs to flow through the Department of Medicine or Division of Nephrology and come back to the transplant nephrologist. So I think because we are in a unique spot, we get paid by different sources, and our division heads are not attuned to those different sources. Apart from being transparent about salary, we need deeper understanding from the higher ups about how the funds flow in transplantation, period. And the hospital needs to be more supportive of that. So I think we really need to push ourselves further via these surveys and other metrics, so we can help, you know, a better salary, negotiate a better salary, and flow of funds for transplant nephrology.
I agree. I think that's an important point, and something that as leaders, most of the folks on this call are leaders in their organizations. We should be working inside our organizations to help achieve that. And if for no other reason than it helps align incentives, which is extremely important, because we're a lot more effective as centers if everybody's pulling in the same directions. And let's be honest, most of us are not doing this for the money. Most of us could have an easier job that pays just as well. So this is transplant is passion work for the people who are in it, but it is still a surrogate for some of that incentive alignment. And I think it's unfortunate when we put people in a situation where if they're sitting down with the nurse and spending an hour reviewing patients, if in the back of their mind they're thinking, gosh, my incentive comp is going down because I'm doing this, that's a bummer, because that's exactly what we should want our transplant physicians to be doing, and we should be structuring the way we measure and compensate according to exactly the types of goals that we're trying to achieve together. All right, we've got a couple more questions coming. A lively discussion, which we appreciate. It's rallying here at the end. I was worried we wouldn't get to 5. Now I'm worried we won't be able to get to stop on time. Do you think there should be a one-size-fits-all structure to determining compensation for transplant nephrology? I'll quickly say I don't. I think different institutions vary substantially. I would like it to be maybe a little less variable and more transparent than our survey helped expose that it is today. But I don't think there's an easy one-size-fits-all answer. Anybody else have any?
Right. I also think that it's due to, in part, differences of what a transplant nephrologist might be asked to do at that institution. So, for example, are you performing any general nephrology, any dialysis care to non-kidney transplant recipients like liver, heart, lung? You know, all of this can kind of impact things. So I think it's hard to do a one-size-fits-all. based on academic, non-academic, and then the roles and responsibilities, both inpatient and outpatient, that a transplant nephrologist might be asked to do.
So just to add to that, I think few things can be standardized, like compensation for non-billable activities. It should not be only 1/3 centers. The respondents are saying that they do get compensated, 2/3 don't. I think that those things should be standardized, and that would help increase the compensation for transplant nephrology overall.
So I think generally the transplant nephrologists are the bleeders for the division, right? Nobody likes us. We are orphans. Neither do we belong to the transplant center, neither do we belong to the divisions, because we can't make our RVUs if the targets are too high.
Yeah, and Asif Sharfuddin added that comment as well, agrees with Dr. Doshi. The transplant nephrologists are stuck between academic medical departments, transplant surgery, and the hospital, and it's true. And I think we should work to unstick that a little bit to the extent that we can. Another question is as well: should there be a set expected dollar amount laid out by CMS or AST for medical director role beyond clinical care? I think this kind of follows the last question. I think I don't know that we would likely say that that's the best plan, but I think Dr. Singh correctly mentioned that there maybe are some things we could do, and this is something we could at least consider exploring through this work group, is whether there's room for any sort of statement or white paper around the importance of having a methodology for ensuring compensation for non-billable effort. We can certainly take it back as a discussion point. I think he made some good points in that area that I would be agreeable to. Any other thoughts?
Yeah, I think setting a standard dollar amount for that role is going to be difficult, because it is dependent on the institution, the cost of living, how much time they are devoting in administration, and many other factors.
Maybe there could be a dollar amount set to an hour of non-billable service, because it is like the median Medicare amount, salary for a nephrologist. Based on that, they decide how much time you spend, et cetera, et cetera. So that can be more standardized, because every institution has their own, reference salary to base that 20% time that you may spend, or 30% time you may spend in non-billable activities. But there is definitely a need for a lot of standardization for reporting non-billable activities, for probably standardizing the dollar amount for time spent, per unit of time spent doing those non-billable activities. And I think for that, we need cooperation of all the transplant nephrologists to respond to the survey. The more data we have, the more we can help each other to get to a better spot than where we are today.
I think in future surveys, we could try to hone in a little bit more specifically on compensation for directors, because this is a question that came up even before the webinar. And really, we only had additional income reported by 9 respondents for their medical director responsibilities. So that's hard to glean any information from. And I know that when I was negotiating my salary when I became medical director, I thought about other really high volume programs. I reached out to medical directors there, and then I realized that compensation is not just a dollar amount, but it's also time to do those administrative responsibilities that really are not billable. So making protocols, and everything that goes along with being a medical director, there's a lot of non-billable activity there, and negotiating time to do that is also part of your compensation beyond the money part. So in the future survey, I think definitely we had a really high number of medical directors that responded. We didn't get specific monetary data from very many of them, but that's something that we've gotten from you all that you're interested in.
All right, so we have a question here. I like the concept of transparency for compensation for all of the reasons mentioned. Should these data be released annually or biannually by transplant centers and be available through AST as an ongoing effort? I think regardless of whether we think that should happen or not, I don't think it's realistic to think that if we reached out to all the transplant centers that they would just release this information. I think that would run into a lot of institutional bureaucracy. That is part of why we took initially the approach of asking people directly to report on themselves. And so I think your desire to see this updated regularly is nice to hear, because I think speaking only for myself, I would like to see this work group continue to do this on a periodic basis, especially give us the opportunity to learn from this experience to maybe make it an even stronger survey in the future. And so that would be my thought, is that we should continue down the path we're on and try to make this a somewhat regular event. Probably certainly not as often as twice a year, but on some regular basis. Any other thoughts?
I agree.
All right, I'm going to finish with
say
one.
that from a biannual standpoint, that would be difficult given the amount of time that it took us to do the survey.
Yes.
If you notice, the survey was released over a several-month period to get the number of respondents that we had. And then just going through the survey results has been pretty time-consuming as well, although really grateful to have the opportunity to do it.
Yeah, it turns out none of us get paid for that either. We didn't know that as a survey question, but it is a labor of love, though. So
yes,
yes, for a good cause. So.
Good. I'm going to finish with one last question here, because I know we're out of time and I'm about to get the vaudeville hook if I'm not careful. So put to the rest of our panel, what do you suggest? How can one use the data revealed today when looking for newer jobs, especially for fresh fellows out of fellowship? So I want to, for our young participants, our future leaders, let's get advice from our expert, accomplished directors here.
I think that's one of the goal of this task force, right? Is to have forums, either virtually or in person, and talk about this. We may not have real hardcore data to share with people, but at least we have our experiences. As Christina mentioned, right? That when she was offered a job, she called a few people, and this way they have a collective group of people, and based on the location and where they're going on the transplant center volumes, they can reach out to the right people and seek advice till we get.
Yes, I would like to put in a plug for AST in general and just being involved in the AST. For example, Niraj and I, before we were even on this task force, had a direct conversation about compensation and medical director compensation in particular, because both of us trained at the same institution and we had met each other, over a decade ago. And that was really helpful for me to have him. And I've met so many people through the AST that I think it's important to not only know your peers, but also people, that have the 5 or 10 years experience ahead of you. You can use results of the compensation survey as a starting point, but then, really talk to individuals in order to flesh out, for you, what seems to be an appropriate compensation package.
So my suggestion would be that we, as a AST Medical Director Task Force, we have a hub, online hub, and they should join. That would give them a great platform to interact with other people. The second, as KPCOP, we have a mentoring program where they can actually can get linked with a mentor, a senior person, who can also help that new person in that medical position, and guide them about the compensation and other things.
Thank you. We appreciate it. So I think that's a great way to close. And I want to thank our panelists today. You guys did a great job with the presentation and discussion. And I want to thank our very active audience for an extremely engaged participation, which makes for great discussion. And most of all, I want to thank the people who filled out the survey, because that's what gives us the data to be able to put this together. So thanks to everybody for a great job.
Yeah, and thank you, Mr. Preczewski, for moderating, also for Dr. Klein, and of course, Doctors Doshi and Singh for today's session. Again, I would also like to thank our attendees for having such a great question and answer, for joining us today. For those with questions we didn't have time for, but it looks like we got to all of them, we can follow up with you. We will also be sending out a recording of this to everyone who registered today and either was not able to attend, or for you guys who are here with us live. So thank you so much, the AST. Thanks this panel for the great work that you did. Thanks.
Thank you.
Thank you. Good evening.